Well, welcome everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. Quick footnote, I've been on active surveillance since 2009, and I'm still a member of my local support group. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment, but a management plan. I would like to remind everyone that we are not anti-treatment, but anti-unnecessary treatment. So a couple of quick housekeeping measures. We are going to hold all questions until after the speaker is done. You can submit questions in the chat box, which we will try to address. And at that time, you can also click the raise hand button from the bottom of your Zoom window toolbar. And if there's time, we'll try to call on you. Please keep yourself muted during the meeting. The speaker presenting here today is generously donating his time, so we want to be respectful of that. We are not here to dispense with any medical advice. Nothing said during our meetings by our speakers, ASPI, or the audience should take the place of consultations with your medical professionals. Also, you do not need to feverishly take notes during the talk, as this meeting is being recorded and will be available on our website in approximately 1 week, and you will get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you'll be automatically notified when the video is posted. Last item is watching the meeting. If you'll notice in the upper right corner of your Zoom window, there's a button that says View. When you click that, you can switch between gallery view, which is everyone, or focus on the speaker. We really recommend selecting speaker, which helps you focus on the topic at hand versus what someone in the audience is having for lunch. So without further ado, I will turn the meeting over to Howard Walensky, the organizer of this meeting, to introduce our guest. So relax, enjoy the meeting, and I hope you all leave a little bit smarter. Take it away, Howard.
Thanks, Bill. Welcome, everybody. Our speaker today is Dr. Peter Carroll, professor in the Department of Urology at the University of California, San Francisco. He's been a pioneer in active surveillance for low-risk prostate cancer since the late 1990s. Dr. Carroll is a recipient of many awards, including recently the Chodak Award from ASPI for being a pioneer in active surveillance. As it happens, today would have been the 77th birthday, or I'm sorry, I got that wrong. Today is the 5-year anniversary of the death of Dr. Gerald Chodak, who laid the foundation for active surveillance and was the ASPI group's first medical advisor. Peter Carroll today will speak about the past, present, and future of AS. We'll have a question and answer afterwards. So Dr. Carroll, the floor is yours.
So I'm going to talk about my perspective on active surveillance, and I'll have a few disclosures to begin with. I remain a very busy surgeon, okay, but I operate only on people who benefit from it. And if we want to talk about that later, I can tell you who that might be. I think overdiagnosis and overtreatment remain problems. And I also think that prostate cancer is often undertreated. So we have this paradigm of overtreatment on one end and undertreatment on another. And I think, and I tell this to urologists all the time or internists, I don't think you can ethically screen patients without offering surveillance for low-risk disease. In fact, I think the biggest complication from a biopsy is not infection. It's like 1.5%. It's diagnosing a low-risk tumor which does not need to be treated, and it gets treated. This discussion should be discussed at the time of screening, not after the diagnosis. Even when you do refined, I'll show you, even when you do refined screening, MRI, serum urine, biomarkers. So again, we're trying to decrease biopsy rates. About 30% of men still get diagnosed with low-risk disease. So even if you try to avoid detecting low-risk disease by doing MRIs selectively, by doing 4K, prostate health index, ExoDx, or others, you still identify patients. It may be a fewer number of patients, but in the aggregate, it's still a significant number. The past is screening was wide and was repeated. So people underwent screening through all age groups. And it was actually a lot of screening in men over the age of 70, and it was repeated screening. That means they got repeated PSAs. Biopsy was offered to all men with an elevated PSA or digital rectal examination. That means if you had a suspicion of disease, you just went right to biopsy. All lesions were treated. In fact, this idea of surveillance was not a concept. And generally, the people were treated with one form of therapy. Hormonal therapy, again, these were like antagonists, Lupron, orchiectomy. You had surgery and radiation. We didn't have these variations. We didn't have focal therapy. We didn't have combination therapy. So it really was a very narrow field. The more recent pass was we went from screen all to treat all to screen appropriately, biopsy some, and treat some. So I thought the antidote to and I wrote an article in the mid 90s or late 90s on overdetection, overtreatment, or both. And I thought the antidote to overdetection was active surveillance. So I thought you could diagnose disease, but to avoid overtreatment, just offer active surveillance. And I found that even now in the United States, the treatment rates for low-risk disease still remain high and quite variable across the country, even within practices. So still 40% of men at least will get diagnosed with low-risk disease, still undergoing necessary treatment. The other thing in the more recent past was surveillance was generally limited to very low-risk disease. In fact, it was generally thought to be very low-risk disease, which I can tell you has gone away. There is increasing interest in, sorry about the typos here, but increasing interest in being more inclusive. And I'll show you there's an interest in something called risk reduction treatment, focal therapy. Now, just to give you an idea, we probably have about 3,000 men on surveillance with long-term follow-up of many. We have a big data set, and it allows us to answer questions. So just for men out there considering surveillance, I'm going to show you what to expect. So if you look at what I'm showing you here is upgrade-free survival. So if you're on surveillance, usually what happens is progression is noted based on biopsy. It's usually not staged. You don't go from a T1, T tumor to a T3 or 4 tumor. That happens, I'll show you, but rarely. Most progression is identified by biopsy. And what I'm showing you here in these curves are reversed. Grade group 1 is here in gold, grade group 2 down here in blue. So at UCSF, we actually have a fair number of patients who are not just low risk, but intermediate risk. And this is the upgrade-free survival rate on surveillance. So a good rule of thumb is that about 1/3 of men on surveillance will show a change in grade by 5 years and 50% by 10 years. I'm picking up a little hiss in the background there. I don't know if that's me or just anyone. Yeah, okay. The other thing to note here is you see the drop off of the curve occurring early and then starting to flatten a little bit. And the reason for that is that much upgrading is not because of biological change. It's just an artifact of biopsy. That means that the disease was there and you just missed it. We're seeing this curve flatten a little bit more now that we're doing MRI, and I'll talk about biopsies in general. Major upgrade. So for us, major upgrade is when you go to a primary pattern, grade group 3 or T3 disease. Major upgrade survival is less common. So about 80% of the changes we see are what I will call marginal. You go from a 3-3 to a 3-4. But on occasion, you'll see a more major change. Again, more common in those with grade group 2 or higher, much less common in those with grade group 1. And if you look at treatment-free survival, it's a little bit better than overall progression because a lot of men who change get on progression we don't treat right away. Again, these are people with marginal changes, small change in volume, small change in grade. We'll continue to keep on surveillance. If you look at overall cancer-specific survival, metastasis-free survival, the overall survival is 97%. Men die of other diseases. Prostate cancer-specific survival is 99+%. So on surveillance, it is very rare that a man will die of prostate cancer. I quote 1%, as long as they're followed carefully. Metastases-free survival is also quite good. We have about 1 to 2% of patients who develop metastases, usually regional, not distant. The other thing is, does delaying surgery affect outcomes for those with grade group 2 disease. So the thought is that, boy, unfortunately, neurology, radiation oncology is, we started to, I'm going to comment on this in a bit, but to dichotomize prostate cancer. This idea that grade group 1 is one thing, but when you go to grade group 2, it's like falling off a cliff. It's a major change. It's actually really not, as I'll show you. I'm going to comment on this as it relates to this whole idea of renaming grade group 1 disease. So we actually looked at this, and these are the curves right here. So these are men who progressed, underwent treatment, and then developed, either had additional treatment after surgery or had a detectable PSA. The overall survival rates are no difference. But it turns out that if you have an upgrade and you get treated, there is no difference in outcome compared to those men who get immediate radical prostatectomy. So you can tell men that this window of safety stays open for a long period of time. For those who progress and then wait for a year or two to have surgery, there's a small change, but it's not driven by the timing of surgery. It's actually driven in we call multivariable models, that in fact it's actually volume that drives these things. So a high volume upgrade is different than a low volume upgrade. But this suggests that a lot of men who upgrade don't need immediate treatment. What predicts for progression? We have looked at all kinds of things. These are the things, again, we have this large data set. I have programmers, statisticians. We've looked at age, PSA density. People forget about PSA density. Every analysis we do, PSA divided by the gland volume is a strong predictor of progression. The cut point of 0.15. It is cheap. You can see it on your MRI report. A lot of men and their physicians don't recognize this. T-stage, MRI, ultrasound, timing of treatment, genomics, we've done a lot of work with volume, ethnicity, histologic subtype, I'm going to comment on that, timing of treatment, and biopsy results. This is the predictors of upgrade. So if you want to take away, this is it. So age, okay? So interestingly enough, a young age is protective. We showed this many years ago. I think was the first publication to show it. It's an idea I got when I was visiting Hopkins. So Bill Catalone asked a question about age. I called my programmer and we came out with the results. So younger patients tend to have more favorable tumor than older patients. Totally counterintuitive, but every analysis we do shows this. And again, it supports the idea of surveillance in younger patients. PSA density, as I mentioned, PSA density over 0.15 tends to predict for progression versus those with a lower PSA density. Biopsy genomics, again, I put GPS here, but you could put in Decipher, Polaris. We also see that a high PIRAD score at diagnosis, or one that develops over time, predicts for progression. Also, volume grade group 2, if you look at just having a grade group 2, 3, 4, doesn't change much in one biopsy, but if you have multiple biopsies, it does predict. If you've had a negative biopsy before, that decreases your risk substantially. One of the things we've looked at is this issue of grade group 1 volume. I'll come back to this, but a high volume grade group 1. So most grade group 1 tumors are low risk, about 80 low volume, so about 80%. This is just not UCSF, but across the board. Most men with grade group 1 disease have low volume disease. About 15 to 20% will have high volume of multiple cores. That does predict for progression, but not outcome after surgery. So again, a high volume grade group 1 is still can for surveillance. You calculate PSA density by taking your PSA and divide it by the gland volume, either calculated by ultrasound or MRI. If you look at your MRI report, they'll have a volume at the top. So you take your PSA, divide it by that volume. You can do it on ultrasound as well. We've shown you can do it on either one. So the key here is when we have all these markers, you can identify markers of progression that allow you to tailor surveillance. So we no longer need to do biopsies every year. You don't need to do that. You do it in some, but not all. If in fact you have a high volume disease, high genomics, PIRADS 5, I'll show you something about histology. These are the patients who are more likely to progress, who will require careful surveillance. Look, this issue of 70 to me is ridiculous. That's ageism. It depends on your, I'll show you this actually in some data shortly. It depends on your overall health. Patients with poor health, they can abandon surveillance. You know, if you're at risk for a major cardiac event in the next couple of years, monitoring your PSA is unimportant. If you're 70 plus and have the 10 to 15 to 20-year life expectancy, I'll show you the data that you may want to continue some form of surveillance. Less intense surveillance, low PSA density, if you have a negative biopsy, favorable MRI, favorable genomics, these are the patients who require less intense follow-up. Is there a role for biomarkers other than MRI? MRI is a biomarker. It allows for more precise biopsy. I still see men going to biopsy without an MRI. I think it's ridiculous. Many men get unnecessary biopsies, and the biopsies that are done are not as precise, and you haven't staged the tumor. Again, what I'm just showing you here, whether you use Prolaris, Oncotype, or Decipher, I'm just showing you the hazard rate for progression. So these do predict for progression. These can be costly. They're frequently not utilized very often. The value to these markers are not in the low volume Gleason 3-3 or grade group 1 disease. The value is actually in higher volume grade group 1 or grade group 2 disease. That's where you start to see a spectrum of these biomarkers. Very important nowadays. It's interesting. The pathologist, when you look at Gleason 3-4 or pattern 4, it turns out these pattern 4 cells have different histologic subtypes, morphology, shape. This is very important, something we've been doing for several years now, recognizing that these shapes predict for a worse outcome. So again, I'm just showing you, again, this is just morphology here. This is what you see, the pathologist sees these different shapes. And what I want to point out is, and I say this to all pathologists nowadays and urologists, that if you're not recording this, again, this is again in grade group 2 and 3 disease, these histologic patterns, they predict for outcome. And there's no cost. You just have to have the pathologist understand how to grade these. And the terms you want to look at are something called introductal or large cribriform histology. These are adverse histologic subtypes. So when you see these things, these tumors are more aggressive compared to those with things we call glomerular or small cribriform or other things. So I'm very hopeful that, in fact, pathologists will start to report these routinely. Right now, at most major medical centers, like UCSF and others, they're recording these, but it really should be done. And this just shows you the data. This is like unfavorable histology versus favorable histology. This is a radical prostatectomy series from Canary we're part of, and showing you that, in fact, you could have the same stage and grade, but depending on this subtype, your risk of biochemical failure or metastases is totally different. Again, it's easy to do. And this is data from UCSF. What I'm showing you here is a borderline and favorable outcome versus unfavorable. So if you have these histologic subtypes, this morphology, you're more likely to progress. The nice thing about this is what I'm showing you here is the Decipher score compared to the histology. So in fact, what it's saying here is that 80% of the time, the histology will correlate with the biomarker. So you may not need to get these biomarkers if your pathologist just records this histologic subtype. Again, this is for those men who have pattern 4 or 5 on the biopsy. Now, Howard asked me for new biomarkers. What I'm very interested, me and the world is interested in the impact of AI, artificial intelligence. And this is going to have major impact in two forms of things that we're doing, or two domains, radiology and pathology. So again, in radiation, in radiology and pathology, what you do, you get these very complex images, you put them in front of a pathologist, frequently of variable training, and they go ahead and make a diagnosis. And this technology is not available around the world. The expertise, we see this all the time, the expertise is not quite good. So what we're doing at UCSF, and it's being done at some other centers, but I have 2 slide scanners. So what I've done, again, I've operated in a lot of patients. We've had surveillance in a lot of patients. We have known outcomes. We have their consent to use their tissue. And what we're doing is we're scanning the tissue. I have 2 of these scanners. They work day and night. they scan these images, and we're using algorithms to predict outcome. This becomes important in two situations. One, we'll discover new biomarkers, but two, will give more accurate grading. What I call democratize oncology, because nowadays you get diagnosed with the cancer anywhere in the world with a biopsy. You can send that, what I hope is you'll be able to send that image anywhere in the world to put it through one of these algorithms and get a more accurate diagnosis and prediction. So you'll centralize expertise, you'll improve prediction at lower cost. So again, you may not need a complex biomarker. You can do this just by scanning histologic images and sending that image, which we can do now in the cloud. So stay tuned. I have one cohort already in men who've been treated with surgery, predicting outcome, which looks good. I've scanned the slides of about 1,550 men who've underwent surgery. That's being analyzed currently. And I'm starting to scan right now men on a large cohort of men on active surveillance to see if we can predict progression and worse out. For us, we really want to predict adverse progression. So predicting minor progression is not as important. Is to tell the patient, what is your risk of having something more major happen? And I have about 650 patients. We have a selected cohort. You build these cohorts where you can answer the question. Prostate cancer now, increasing interest in being more inclusive. This idea, if you're grade group 1, you're on it, grade group 2, you're not. There's an interest in risk reduction, focal therapy, interest in renaming Gleason grade group 1, or this whole issue of grade group 1, or Gleason score 3-3. So is there any rationale for focal therapy? Well, the rationale, by focal therapy, I mean you don't treat the entire prostate. You go right at the tumor itself. With surgery and radiation, you're generally going ahead and removing or radiating the entire prostate. But about 1/3 of men are presenting with what we call relatively focal disease, or by focal, I mean that they have a dominant tumor, sometimes without any cancer anywhere else, sometimes with a small amount of cancer, low risk on the contralateral side. So focal therapy, the rationale is that we have better localization techniques now. We have MRI. Data from UCSF suggests that adding PSMA PET with an MRI better localizes your cancer. Limited morbidity with focal therapy done well. The risk to changes in sexual or urinary function, bowel function is quite low. You could obviate the need for an intensity of surveillance. If you go ahead and these small lesions, you treat them, maybe these patients don't need quite the intensity of surveillance. And I'll show you this whole concept of risk reduction. Concerns, is it overtreatment? I mean, do these men really need treatment? The data on focal therapy look good at 3 to 5 years. What we don't have are good studies at 10 to 15 years. And the quality of the studies are quite variable. Some men get analyzed very carefully up front, but then they only do biopsies at cause. And the issue, does it make secondary treatment if needed more morbid? I can answer that. I've operated on several men who failed focal therapy, and only 2 times. And these are patients, one treated in Europe and one in Florida, where it was more difficult to do, but it's usually pretty straightforward. So where do we use focal therapy? Well-localized unifocal disease. This is a patient, again, this is a PSMA PET scan. I'm running a large trial looking at PSMA PET in men with grade group 2 disease. And for me, the issue is, can we better identify the extent of disease in the prostate? And this is an image right here. Again, this is the patients lying on their back, abdomen up here. Here's the pubic bone, right and left hip. This is the pelvis here, rectum here. This right here is the prostate. This man, you see this tumor light up. He had at least in 3-4 disease on the left side, and you can see he's got a well-localized lesion, mid-gland, and you could consider, in this man, he just had the one lesion, the one cancer right there, and he's a candidate for focal ablation. We have a big program in that, and there are several around the country. The concept of risk reduction is sometimes we'll see a man who's got a dominant tumor on one side and a micro focus on the other. So it would be a patient like this who's got this dominant cancer here, 2 or 3 biopsies positive for at least 3, 4 or higher on one side, and a micro focus of invisible tumor on the other. So the thought that many have is, well, look, I can tell you based on our work at UCSF, more than 80% of the time, the tumor that progresses is the target. That means out of target progression is uncommon. And we can talk about biopsy techniques later because there's some new data on that. So the idea for some patients is we'll go ahead and treat the dominant tumor with focal therapy. Don't spread energy across the entire prostate, and then watch the other side. So the concept is you're reducing risk. You're treating the dominant tumor and watching the microfocus on the other cancer. And that's an emerging theme. I hear over and over again, let's rename grade group 1 disease. So let's stop calling Gleason 3-3 a cancer. I disagree with this notion because I think we're at a time for a very teachable moment here. I don't think we can dichotomize cancer. First of all, it is a cancer, so it has pathologic hallmarks of the cancer. Again, it has hallmarks that make suggesting it's a much less aggressive cancer. But the rationale for renaming it not a cancer is it decreases overtreatment. It may eliminate stress or anxiety, and it could eliminate being denied overcharge for life insurance. When that happens, I've gone out for my patients on surveillance. I've gone after insurance companies on this issue. The concern it is a cancer. You worry a little bit if you call it a non-cancer would patients not comply with surveillance. Could the terminology be confusing for physicians and patients? And remember, we're not just talking about prostate cancer here. This whole issue over detection is becoming an issue for many cancers. And stay tuned. We have these multi-cancer detection tests, Galeri. So brace yourselves for a new round of early detection. Would insurers not reimburse for testing? So if you not call it cancer, they say, well, look, you don't have a cancer, you don't need an MRI. My biggest concern is you're dichotomizing prostate cancer when it's a spectrum of disease. That means if you say there's just not two kinds of prostate cancers, actually it's a spectrum of disease. What I'm showing you here is new data from UCSF, and I'll go through this with you. But what I'm showing you down here is something called the CAPRA score. So for those of you who want to get a good estimate of your cancer, taking into account age, PSA, volume, and grade, you can go to our website, and it's on many websites. It's called CAPRA, C-A-P-R-A, Cancer of the Prostate. This is something we developed many years ago at UCSF. We have two scores. CAPRA-S is when you've had your surgery. CAPRA is when you've had the biopsy. But what I'm showing you here is these are all, so on these CAPRA-S scores, you go from 0 to 12. Okay, so that means 0 through 2 is a very low-risk tumor. 12 is a high-risk tumor. That means these are people with high PSAs. You have a higher risk of recurring after surgery. What I'm showing you here is in the blue is grade group 1, grade group 2, grade group 3, and grade group 4 and 5. And I'm just showing you here that there's a lot of overlap here. So at least one in 3 men, about a third of men with grade group 2 disease have the same characteristics as grade group 1. So to call one cancer and one not boggles my mind a little bit. So you can see here that actually some men with grade group 1 disease actually have higher risk when you take into account everything else. And this is the CAPRA score, CAPRA-S based on biopsy. So I am using a pointer. I don't know why it's showing up on my screen, but here on the 0 through 2 here, again, I'm just showing you here. There's a lot of overlap between grade group 1 and grade group 2 disease. So I think the big thing for me is we need a teachable moment. We have a teachable moment here to better sense what cancer is. You go back 100 years ago and infectious disease was lethal. And we need a modern 21st definition of cancer where we have understands the spectrum of disease and our approach to the spectrum. And this will become more common as we get more of these tests available to us. And renaming grade group 1 does not get us to a 21st century definition of cancer. So we need a modern definition of cancer as a spectrum of disease with a measured response. And renaming doesn't get us, in my opinion. Again, it's a growing issue with all cancers in all developing worlds. And newer diagnostic tests may make this more of an issue. Again, serum tests, whole body MRIs. We're detecting breast, thyroid, other cancers that are indolent. Can we stop at some point? Well, I'm gonna pay homage to Howard on this. So this is great. This is a national story. Should older patients with prostate cancer jump off the active surveillance train? And Howard he went around and asked a lot of people what would you do? But everyone recommends de-intensifying surveillance, minimizing biopsies. But the responses going forward there was a lot of different thoughts on this. About 44% said they'll continue surveillance with an annual, semi-annual PSA, MRI, genomics, and by a third say we'll stop it or move to watchful waiting. So this caught my attention. And we have an article coming out which has created a lot of interest, and we acknowledge Howard's. We acknowledge him in the article about this. And what we looked at here is men on surveillance with grade group 1 disease who had 3 or more biopsies in surveillance, and they hadn't progressed for at least 5 years. Now, we didn't look at age here because I'll show you that age goes both ways on this. So you don't want to look at just age alone. You want to look at the entire spectrum of age groups. And we looked at upgrade-free survival, and we looked at something called major upgrade. So again, most upgrading is minor. I mean, you may see a small change in volume or grade, but we want to know, what is your risk, significant risk going forward? What's your risk of metastases and prostate cancer specific survival? And we looked at data at 10, 12, and 15 years. And we did this with a lot of well-recognized statistical analyses. And here's the data. Okay, it's not showing up there. Okay, so I borrowed this slide. I will get this out to the group here, but it's not showing up, but this box fills. And what you'll see is actually the upgrade-free survival. There's a significant risk that you'll see a change in volume or grade going out 15 years. Major upgrade-free survival is much more limited. And metastases-free survival is very good. That means that the likelihood that that if you've been on surveillance for 5 years, had 3 biopsies, 5 years or more, 3 biopsies, the likelihood that you'd have a major event is quite low. Overall survival depends on other comorbidities and not prostate cancer. Prostate cancer-specific survival is excellent. So it suggests here, and I'm not sure why it's not popping up. What we showed here, again, it's a big table, but the interesting thing here, which predicts, we something we call a multivariable model. That means we take into account everything. So we take into account everything. Volume and PSA predict any upgrade, but if you look at major upgrade, age does. And by age here, older patients have a greater risk of a major upgrade. And these are the upgrade-free survival. So again, these show that we only looked at people who had 5 years, greater than 3 biopsies, no change. And you can see here, for men less than 60, the likelihood of any change was lower than men who were older. And this is a major upgrade. So again, we saw there was a major upgrade of about 10 to 15%. By a major upgrade, it was going from a grade group 1 or grade group 2 to a grade group 3 or higher, or T3 disease. So actually older patients have a higher risk of a more major upgrade, but it's still relatively low, 10 to 15% out to 15 years. Again, overall survival over prostate cancer specific survival is excellent. So that means that if you've been on, I don't know that I would stop, you can look at the statistics here. The major upgrade free survival is actually quite good. And if you said, gee, I don't mind taking some risk, you could stop, but there is a risk out there. Overall survival is, again, determined not by prostate cancer, because the risk of death was I think almost 0. 2 other points here before I kind of conclude. One, someone asked me, we have a big interest in lifestyle and exercise, and we've done a lot of studies. I've done it with Dean Ornish. We have a large group, June Chan, Stacy Kenfield here at UCSF. And if you go to our website, we have some publications, which we've done with the Prostate Cancer Foundation, on diet, nutrition, and exercise. We have a big interest in exercise, and there's a biological rationale for both. The #1 killer of men with prostate cancer is not prostate cancer, it's cardiovascular disease. So changing in lifestyle actually puts you at a lower risk of things other than prostate cancer. You lower your cholesterol, decrease weight, quality of life gets better. We've actually seen sexual function get better. So many of our patients have adopted diet and exercise, and we have a big interest in exercise as well. We've looked at randomizing patients to their usual care to an exercise program, and actually getting the benefits of exercise. You don't have to run a marathon to get benefits from exercise. The level you need to do to get benefit is rather low. The one other thing I'd say about targeted biopsies, a lot of interest in, do I need a systematic biopsy? Can you just go at the target? So on men on surveillance, you need to go take 12 biopsies throughout the prostate and then just take 2 from the target. And we just completed a study. Again, this is coming out very shortly, I think in the next month. And we have found that actually the progression that occurs in the target. If you miss it, it tends to occur right at the edge. So we're telling men now and urologists that you need to sample the target a little bit better. Out of target progression is very uncommon and almost always this low volume, favorable histologic subtype. So better, if you undergo a biopsy and surveillance, it could be that if you have a good urologist, they're doing fusion-guided biopsy, not cognitive fusion-guided, that you might be able to just answer this question better by target alone, just sample the target better at the periphery. Again, for this thing with Howard is, again, patients without progression at 5 years in surveillance have high overall upgrade rates, but low rates of major upgrade, and very low rates of metastasis and mortality at 10 to 15 years. Older age is significantly associated with increased upgrade and major upgraded surveillance. And volume, again, is associated with grade, but not major upgrade. So I think this confirms the safety of surveillance in low-risk patients, and you can de-intensify surveillance if you haven't progressed. But I'm not sure if your health is good. If your health is good, I would continue with some form of surveillance, which could be PSA. It's interesting, when we look at our surveillance series, PSA is not a very good marker early on, but become a bigger marker later on. And you do see these rare changes. In fact, we're trying to record them now, is that most progression on surveillance is just an artifact of just not hitting the cancer to begin with. But we have seen, and I'll get to Howard, others later, is the risk where we see men who have low-grade disease and then boom, they have this major biological change. It's rare, and Lori Klotz has reported it as rare as well. It should not dissuade men from surveillance, but it has to be kept in mind. And this issue of de-intensification has got to be addressed in future guidelines. Thank you very much.
Thank you, Dr. Carroll. I think we'll turn it over to Mark for some comments. Then we'll go into question and answer. I have a couple of questions, but I'll wait for Mark.
Well, thank you, Howard, and thank you, Dr. Carroll. I was thinking while you were talking, one of our issues, Dr. Carroll, is about helping men move beyond their anxiety, their unnecessary anxiety. Because what happens with the unnecessary anxiety is that men move on to treatment only due to anxiety. And treatment may treat a disease, but it won't treat the anxiety. You'll probably still have the anxiety. In fact, people that have had treatment, they're going on with their testing and they still have that anxiety. And so I wanted to say about you, Dr. Carroll, your voice goes a long way, and your knowledge goes a long way in helping men to reduce that anxiety. And I was actually too impressed with you and all the work that you've done in promoting active surveillance. I was impressed because 2 of our prior awardees at your ceremony showed up and spoke about you and your contributions, both Dr. Klotz and Dr. Albertson, who were giants in the active surveillance world. And so it's really good to have presented the Chodak Award to you and well deserved. And why some of you on this call may be thinking, well, why are we doing these awards? Well, why we do these awards is active surveillance is not where it needs to be. Even yet, even today, it's not where it needs to be. Now, ASPI has made tremendous progress in avoiding overtreatment, but we have a tremendous journey to go. And, you know, we focus on overtreatment. We're now kind of trying to focus more on over biopsying and safe biopsying. We know there's safer biopsying out there. We know about the transperineal biopsying, and many of you too are now choosing that as a way to go. And so but as I said at the beginning of this, our focus is too on trying to help you men who are on this call reduce your anxiety about this process, about this journey.
Right. So let me comment on the issue of anxiety. The antidote for anxiety is, one, you need to tell men before they're biopsied about this phenomenon of overdetection. So what I find is that there's no discussion about this, and then the man gets a biopsy and someone calls and tells me he's got cancer. The discussion has got to start before the biopsy, number one. So I tell a patient, and we have this in language, you know, the goal of the biopsy is to detect something that puts you at risk over your lifetime, not just to detect cancer. And I tell them this. I said, there's about a 1 in 3 chance we'll detect something. And I'm going to tell you, don't treat. That's the first thing you do. And the other thing you do is you show men good data. So, you know, you can buy a loaf of bread with more transparency than healthcare in this country. So as I told a reporter one day, I'm completely comfortable with the decisions men and their families make, but they need to make it on the best information available to them. And that's frequently not the case. You know, anxiety in our patients is low because, one, we've told them about this phenomenon and we've showed them the data. So we show them, you know, these risk things. So I think if you transmit the data to men, you know, we can't undersell the intellect of American men and women. I mean, they can, if you give them the data on this, I think they make good decisions. And the other thing I've found is that for a man on surveillance who progresses and then gets treatment, they feel much more comfortable about their decision. There's less regret compared to a man who jumps at treatment right away. So I think anxiety, to a large part, depends on who you're getting your information from.
Well, thank you.
Mark, I was going to jump in now, and then we can move over to Jeff to
Great.
And open up to
Thank you,
questions from the audience. But Dr. Carroll, I was on a program recently with Dr. Klotz, and he brought up something else that you didn't mention, and I'd be interested in your take. And he was talking about invisible lesions.
Yeah.
What is that about? What's invisible?
Yeah, so invisible means, and I just talked to him about this because he was very interested. I got this idea because Laura and I were at a meeting about 2-3 years ago, and I wanted to ask the same question that he was. So an invisible lesion is, so you get an MRI or an ultrasound, you have a target, you see an abnormality, and you biopsy it. And what you want to know is what's the likelihood that there's a significant cancer that I can't see that sits outside this target? That's the issue. And actually, what I used to say is about 15% of the time, the major grade or dominant tumor was outside the target. But when we looked at our data at UCSF, we found that these off-target lesions were really just at the edge of the target. That means we just missed it. And our most recent analysis, you'll see it coming out shortly, suggests that if you just biopsy the target better, you'll most very few. And I think in our series, it was like 6%. All low volume, favorable histologic subtype. So that means that there's a small amount of cancer, which is small, that's invisible, that sits outside the target. Invisible means you just can't see it. It's a small number if you do the biopsy correctly.
Well, he said he mentioned something that I've heard about low risk prostate cancer, which is, he said, if it's invisible, and there is a genetic component to it, but if it's invisible, it's not likely to spread and it's not likely to kill.
Correct.
So
Correct. Yeah. For us, what we're looking at now is, some people, what we want to know now is, can you go only to an imaging-based paradigm? Only imaging. That means can you take an MRI, do the biopsy, diagnose disease, and then only make a decision about biopsy based on imaging alone? And that's a current study that we're looking at now. And because this is what Mark Emberson would say, who's a distinguished urologist I know well in the UK. So we're looking at that now as maybe can you only image patients and only biopsy them should you see a change in the volume or characteristics of the target. Stay
Gotcha.
tuned. We'll have data on that very shortly.
Yeah, Jeff, do you want to?
Yes, thank you, Howard. Thank you, Doctor, very much. I'm going to try to go in the order of the questions, so please be patient, but we will get to everybody time permitting. I have a question for Mr. Weintraub. How do you calculate PSAD if you were taking dutasteride, which shrinks the size of the prostate, Doctor?
So you can't do it accurately, but you want to roughly double your PSA. So you still have a volume, you want to double your PSA. Because dutasteride reduces PSA by about 50%. Now, it could be as low as 20%, up to 80%, but generally, rule of thumb is about 50%. We don't tell men, so if you're on active surveillance, you've had a good biopsy, and you have BPH, you can, in my opinion, safely go on dutasteride or finasteride. So benign enlargement and cancer are two different diseases, and frequently you'll have to figure out how you manage one versus another. But it's usually decreased by 50%. The prostate volume decreases by about 20 to 30%. So again, just to take into account that, double your PSA is, think that's roughly what it would be off dutasteride.
Doctor, just stretching that question a little bit, would that apply to BPH medicines that are out there, the same rule of thumb?
For the BPH medicines like tamsulosin, they don't change PSA. So the alpha blockers, they don't change PSA.
Okay. Finally, Doctor, a person that has BPH and prostate cancer, looking at the various biomarkers, what would you opine?
Well, first of all, you need to adequately assess their cancer first. So again, you want to know the volume, have they had an MRI? Have they had a targeted fusion-guided biopsy? What's the grade? Have they had genomics? So you want to characterize the cancer first, because treatment of the BPH could complicate later treatment of the cancer. So again, if you have a transurethral resection, exposes the urethra to the toxicity of radiation. So what you want to do is you want to characterize the cancer first, understand it, make a decision about it, and does it need to be treated or not, and then secondarily address the BPH. If you have a significant cancer, the one that needs to be treated, and you have BPH, many men will opt for surgery, which will take care of both. If you're going for radiation, you want to manage the BPH first. That means you want to, decrease its volume, minimize the risk the radiation will exacerbate their obstructive symptoms. But generally, characterize the cancer first, understand what you want to do about that, then address the BPH.
Thank you, Doctor. I have Richard Dixon of Broxville asking the following. My urologist uses a guided micro-ultrasound for my active surveillance. I have had only one MRI since my grade group 1 PC. Is this adequate progression monitoring?
Yeah, so we think it likely is. We think it is. We don't have great data comparing one versus another. But it suggests that an experienced provider using micro-ultrasound can do as well as an MRI. But again, there's technology and there's a person using the technology. So generally, I would ask men to, ask your physicians, why are we doing it this way, and what's the data that you have on this approach? But generally, micro-ultrasound looks like it's comparable to MRI.
All right.
Say, Jeff, can I sneak a couple of questions in?
Sure.
Okay. Dr. Carroll, you mentioned how you thought it was ridiculous that men were not getting pre-biopsy MRIs. And I wonder if you know what proportion of men do. Is this largely an academic practice, or doctors in the community referring people in for MRIs before they do biopsy? And why is this important anyway?
So I don't know the exact numbers, but I still see a lot of men who go for immediate biopsy without an MRI. You know, what you do if you have an elevated PSA, the first thing you do is confirm it. So be sure it's truly elevated. So, you know, the intra-assay variability is about 15%. Biological variability could be up to 50%. So PSA, document it, understand family history, risk, you know, do you have a first-degree relative who died of prostate cancer? And in the past, you went right to biopsy. But again, if you take 1,000 US men and you screen them with PSA, about 250 will have a PSA between 3 and 10. If you biopsy all those patients, about half don't have cancer. They have benign enlargement, didn't need the biopsy. And those who have cancer, about 30% or 40% will have these low-risk tumors. So again, what you want to avoid is unnecessary biopsy in men who don't have disease and unnecessary biopsy in men who don't have higher grade disease. Two ways to do that: do an MRI, or you can do these other markers, you know, ExoDx, 4K, prostate health index. They both are telling you what's the likelihood based, you know, if you have an elevated PSA, what's the likelihood you have clinically significant disease. The MRI, of course, will go one step further and allow you to stage the cancer. You know, we'll see lymph nodes, bone, and the area around the prostate, and allow for targeted biopsy. So again, I can't tell the penetrance. We know it's quite variable. We do think it's available to socioeconomic status. You know, what we're finding now is fewer insurance companies refuse the MRI. So we generally can get this done, but I think it's, in my opinion, best practice.
You know, and this relates to what you were just describing. You also mentioned how the number of men going on active surveillance is shrinking. And we should consider that a good thing, right? I mean, back when I got diagnosed, I'm not as old as Mark or the other Howard, as far as that goes. It seemed that the goal was to avoid unnecessary treatment. Now, would you agree that the goal is to avoid unnecessary diagnosis?
Yeah, so the answer is yes. But as I just mentioned, even when you use these paradigms of imaging and these other biomarkers, about 1/3 of the men you diagnose have low-risk disease. You're diagnosing fewer of them, but if you look at the overall group, you're still diagnosing them. So you decrease the unnecessary biopsies, but you don't eliminate it.
Yeah, Jeff.
Yes.
And by the way, Jeff, do you want to open up the floor to some of the people if they raise their hands?
Well, I want to try to get through some of the old questions, and we'll get to that, assuming we have some time left with the doctor, right?
Right.
I'm good.
Good. Thank you, doctor. I have Alan Carroll. It's kind of a mixed question, but I'll ask it as he writes it, sir. What if you were told you were a good candidate for focal therapy, Gleason 3+4, 1 PRADS 4 lesions, 61 cc prostate size, and I'm sick of getting up to PL9. Is there a way to address both?
Well, remember, if you do focal therapy, first of all, you have to talk to your doctor. I don't know if you're on how you're treating your BPH currently, but if you want to ask your doctor, how am I going to take care of both? Now, when you do apply the therapy, now the therapy could be high intensity focused ultrasound. If it's an anterior lesion, it might be cryotherapy, IRE, interstitial laser. You know, there's a development now of high pressure water vapor. You will get atrophy on that side when you apply it. So that the volume of your prostate may reduce a bit. It may not completely eliminate the BPH symptoms. I think it depends on how bad the BPH symptoms are. And, you know, I can tell you that as a rule of thumb, most men will tolerate getting up twice a night to go. Beyond that, I see a higher bother score. But again, you know, you got to take into account. Now, the first thing I tell you is remember 3-4, low volume 3-4 is a low risk tumor. So you got to be careful. I mean, do you really need the treatment? And, you know, if the slide's been reviewed by an expert pathologist, what's histologic subtype? Do you have genomics done? But we don't always treat 3-4 tumors. About 20% of our men on surveillance, maybe a little bit more now, have 3-4 tumors. So not all 3-4 tumors need treatment. So just be sure you need treatment.
Fine. Brett asks, is proton therapy effective for focal treatment in low-grade tumors?
But if you have a low-grade tumor, I don't think you need treatment. And you may not need whole gland treatment. And in my opinion, there's no knowledge that proton therapy is better than other modern forms of therapy like stereotactic body radiation, HDR, other things. So to me, again, proton therapy is generally whole gland treatment. I don't know that they're doing focal proton, but in general, I think proton's a modern form of treatment, but when you compare it to other modern forms of treatment, radiation treatment, I don't see the value. I mean, we could have it done. I don't know.
Wonderful. David Keller asked the best blood and urine tests between MRI and biopsies.
You mean for if you're looking for tests that diagnose cancer, like 4K prostate health index, ExoDx, the problem is these have not been compared head to head, and frequently the studies that these suppliers quote are different cohorts of population. So some men will use them. I mean, sometimes they'll use these test cohorts where they'll include men who have a PSA, elevated PSA, as well as an elevated PSA in a previous negative biopsy. So you have to look very carefully. I don't know that I could recommend one versus another. I think the key is that they all seem to be reasonable tests. And if you go to the NCCN website, National Comprehensive Cancer Network website, on early detection, I ran this for many years. They'll go over all these tests, but they don't highlight one over another.
Should we have our latest biopsies sent to a company that will run it through an AI program if such exists?
So not yet, but hang tight. This is moving very rapidly. And we at UCSF are very interested in this because it'll reduce the variability we see in diagnoses. So we see a lot of variability on grading. I see some men with 3-4 disease who are thought to have 3-4 disease, but they don't because of this concept of tangential sectioning. But I think this will be the great level. We'll be leveling the playing field here. You'll be able to send your image somewhere. But hang tight. We do have an AI algorithm for men who are going to get radiation to determine the need for hormonal therapy. So about 2/3 of men with intermediate risk disease getting radiation don't need hormonal therapy, and about 1/3 of men with high risk disease don't benefit from it. Now that test is available, but to my knowledge, is not available in California or New York for some reason. We're actually working with
you have your own regulation. You think your country's in yourself.
Yeah,
California and New
right.
York.
It's New York too, as well. So I don't know.
Yeah.
I got to find out more about that. But yeah, stay tuned. I think both MRI and pathology will be able to be read centrally by AI algorithms, which will give better, more reliable information than we currently see, given the variability in radiologists and pathologists' expertise in imaging these things.
Hey, Jeff, I got a couple of questions that were emailed in.
Okay.
One of them is, does capsular abutment, and I don't know what ECE is, capsular abutment with no ECE factor into whether or not to stay on active surveillance?
So to me, so what we're talking about here, think of the prostate like an orange and the orange peel being the capsule. Capsular abutment means that cancer goes up to the peel. Extracapsular extension means it goes through the peel. Now, we have found that using MRI, that this is not a very specific or predictive assessment. So capsular abutment, when we look at it, we look at the capsular abutment and men undergoes surgery, we do not see that's a reliable predictor of extracapsular extension. Actually, interesting enough, at UCSF, not in the community, but at UCSF, we have some superb sonographers. One is Katsuda Shinohara. And actually, his assessment on ultrasound is the best predictor of tumor stage. So you have to go to you want to go to a place that collects data so they can determine how good they are at predicting outcomes. So at UCSF, we collect this information so we can say to men, if you have this finding, you have a 20% or 40% or 80% chance of this. But abutment would not dissuade me from offering surveillance if everything else looked appropriate. And even extracapsular extension, I worry that sometimes I see this all the time where it's been called and it isn't. And we see a lot of variation in PSMA readings.
I have another question from the same person, and he's basically asking, is there such a thing as active surveillance fatigue? Do people quit active surveillance just because they're tired about it? They don't like living with uncertainty.
Correct. Well, I tell you, it's not, I don't think it's uncertainty when they get the information, but I think what they don't like is repeated biopsies. And so I think that's what we have to do is we have to make surveillance less burdensome. So we, it used to be that at some centers you got a biopsy every year. That for many men was intolerable. So actually, what we're trying to do is reduce biopsies. I think you need at least one confirmatory biopsy, but beyond that, we're starting to look that it may be for cause only. So I think the issue is you just got to make it, give men good information, and they have to have good information about the alternative. So if you decide to be treated, how am I going to be treated, and what can I expect? So I mean, I think when you give men information, like most things in life, when you have good information, you make a decision you're most comfortable with. But it's got to be good information on both sides. What's going to happen if I'm staying in surveillance? What will happen if I get treated?
Jeff.
Howard, thank you. Yes, I have a gentleman, Darren Spillman. How can I find a urologist or oncologist in my area who can assist me in an AS program?
Well, it's hard to tell. I think one, if you have a support group locally, sometimes you'll get an idea about providers in your community. I think academic centers are inclined to do surveillance well. Generally, we do see lots of variability, and I can tell you based on region. So I think if you're close to an academic center, you can go to that website and see to what extent they've published on it, they have cohorts on it, they've lectured on it. But you have to do some homework.
Right. Peter from South Africa asked, could you please elaborate on the helpfulness of tracking PSA scores? Does its value lie in the trend rather than the level itself?
Yeah, so generally PSA varies. So you look at trends in PSA. The other thing you look at is PSA density. So again, a PSA of 8 in an 80-gram gland is different than a PSA of 8 in a 20-gram gland. So you want to track its truest trends because you see about 15% inter-assay variability, and biologic variability at low numbers can be significant. So I always tell people you never make a decision based on a single PSA value. You want to get another one. It's trends, but also calculate your PSA density. Again, PSA divided by gland volume. That's a great leveler. I had a patient yesterday. He's 77. He's in surveillance, and his last, I don't know, his PSA went from 6 to 7.5. But his gland volume went from 52 to 69. So actually, his PSA density improved. Even though his PSA went up, his PSA density improved. So again, you want to track both.
We have Mitch from Florida, a fusion biopsy done in the MRI tube in real time versus a biopsy, which is performed with MRI results at biopsy. He's asking about sensitivity and results.
Well, I'm not sure, the endorectal MRI was developed at UCSF more than 20 years ago. We've been funded for 20 plus years. To me, I don't see the value of an in-bore biopsy compared to a fusion-guided biopsy using software, transperineal fusion-guided biopsy. The in-bore biopsies are not easy to do. They're frequently limited biopsies. You generally limit the number. So, I can't, you want a good biopsy done, but I have no knowledge that an in-bore biopsy is better than a well-done transperineal or transrectal fusion-guided biopsy. So I think for time and expense, it's likely that the fusion-guided biopsy will outperform. That's my opinion.
Got a couple of questions on using a biopsy alone without an MRI.
I wouldn't do it. I wouldn't do it. There may be a reason you can't do an MRI, but now there's a lot of MR compatible pacemakers. We do see sometimes a scatter artifact from hips, but in general, the work has shown that a fusion guided biopsy, MR directed, you have a lower likelihood of missing clinically significant disease. So again, I think fusion-guided biopsies are better than just systematic biopsies. Sometimes you don't have a target. And there's still, for one reason or another, biomarker, PSA density, thought that the biopsy might be needed. But generally, you want some kind of imaging done before you do the biopsy.
Jeff, I'd like to pick up on a question that Bob C. brought up. And Dr. Carroll, for years we've heard about the war on cancer.
Yeah.
And then we hear about the moonshot on cancer. And how much of this is just BS? How much of it is real? And as Bob asked, do you think we'll ever see a cure for cancer in our lifetime? Sounds like we're back in the Vietnam War,
Yeah.
looking for a light in the tunnel.
Yeah, no. We've made significant progress. I mean, what has converged is this issue of advanced imaging and genomics, and our understanding of cancer is much better. I can tell you that from my experience in treating this disease for many years, we are much more nuanced now, and we have better understanding, and we frequently can adapt the treatment to the individual patient's risk. Now we're developing these vaccines. I mean, so. Things are moving very quickly in theranostics, imaging, genomics, target identification. The other thing with cancer, look, if we can make it a chronic disease of low morbidity, that would be great. So, we're not going to get rid of disease. We're not going to, the world will never be perfect in that regard. What we can do is minimize prevent it if possible, and minimize the impact of the diagnosis and treatment. But there's considerable progress. I mean, some of the stuff I'm seeing is amazing, in theranostics, AI. It's got to be used well, and it's got to be we're making progress.
Okay. Let's see.
I think we have.
There you are, Jeff. I was afraid we lost you.
I'm sorry. We have a question, a hand up from Robert Wood. Robert, would you like to unmute yourself and fire away?
Okay, am I unmuted?
Yes, yeah, you can hear you, Robert.
All right, for men, let's say with one metal hip, maybe another metal hip, if you're deciding to go for a fusion-guided biopsy, what are the percentages of targeting that lesion when you might have some distortion?
Yeah, that depends on what the radiologist sees. Some distortion makes it very difficult, some distortion less so. It wouldn't, to me, I would still get the imaging, see what it shows.
Would you be using a 3 Tesla or
Okay,
1.5?
So we use 3 Tesla routinely. However, if you go to Europe, many people think 1.5 Tesla is adequate, but we use 3 Tesla routinely.
Thank you.
And Jeff, I can pick up here with George Copens, who said he recently had a HOLLOP procedure performed. His volume of his prostate was reduced from 176 milliliters to 42. And he asked, is a PSA density test still valuable?
Well, it is, but hopefully you were screened before you had the whole lab done. And if your whole lab shows no cancer, your PSA will be lower. I mean, if you've gone from whatever it was to 42, your PSA will be lower, and you still calculate a PSA density. But normally before a whole lab, if you're in good health and a low life expectancy, usually you're screened for cancer because, again, the whole lab could complicate treatment down the line if you had a cancer. And about 15% of people have a whole lab. When you look at the tissue removed, will have cancer in it, usually low volume, low grade. I have seen several patients who were not screened ahead of time who tend to have a cancer, and then you can treat them, but it's got to be more nuanced because you've taken out that central portion of the prostate. So when you do surgery, these tend to have open bladder necks. With radiation, you have to be careful because you have exposure to the urethra to the radiation. So most men who are in good health, who have a long life expectancy before they undergo a procedure for BPH, I think should consider screening for prostate cancer, because how you would treat that cancer could be different. How you treat the BPH could be different depending on the cancer.
Okay, Howard, do we have any more? I have a question if you don't.
Yeah, go ahead.
All right, doctor, I've noticed that now that my PSA has increased a little bit over 10, that I'm not getting a PSA-free reading. I asked a nurse about that, and she said that the particular PSA test, because I'm over that number, does not include a free PSA. How valuable is free PSA in the doctor's eyes?
So I think we've gone beyond free PSA to other biomarkers now. So the key, if you're going over 10, like, what's your prostate volume? I mean, so I don't think not getting free PSA is something of historical significance. You can still get it. It's generally been replaced by other biomarkers like 4K, prostate health index, XODX. But if it's 10 and if you have a prostate on MRI of 80 negative, well, I don't think you need the free PSA.
Howard, do you have anything to fire away?
If I could just
Go
comment,
ahead, Peter.
I have a comment here from Alan to everyone. I have a positive cancer lesion, the left apex, peripheral only 3-4, 4% of tissue cores, grade group 1, 10%. That's a low risk tumor. I'm not sure you need anything about that. So again, you got to be careful. Low volume secondary pattern 4 is a low risk tumor. So, I mean, I would be, focal therapy could be an option, but I don't know that you need any form of treatment. You do have to be a little careful about tumors at the apex of the prostate because the urethra is quite there. So you have to measure the distance between the urethra and your tumor. So go to an experienced provider. But a low volume secondary pattern 4, if all of the things are equal, is generally a low risk tumor.
Yeah. Peter, Bruce Mack brings up 4K and what is that? And I should add, as a reporter for Medscape, I covered a study out of Hopkins where they compared 4K to the prostate health index and found them equivalent. I personally have an annual prostate health index, and that's manufactured by the original manufacturer of PSA, but it adds on a couple of things. But maybe you could distinguish between 4K and PHI.
So what these are tests, they could be isoforms of PSA, or they could be genomic markers. There's many different tests, both urine and serum, some performed after a digital rectal examination, some not. And what they're all doing, the individual test, is trying to predict the likelihood of clinically significant disease. The data in their use on surveillance, however, is quite mixed. I think it becomes important in men who are considering a biopsy, but as a follow-up to surveillance, the data is quite mixed. But there's several more coming out. I tell you, this is an area where there's more and more biomarkers that are being developed to predict risk of clinically significant disease. What I would do is I get those tests when I have a patient who might be older, has a marginal elevated PSA. If I have a patient who's younger, has a significant PSA, I generally go to the MRI. They're both doing the same kind of thing, determining what's your risk of having prostate cancer. The MRI just allows for better imaging, staging, and targeting. So I think it depends on the patient I'm seeing whether I use one, the other, or both. And a lot of times it comes down to cost. An MRI in Europe is quite cheap. MRI in the US is quite expensive.
Now, Norbert Goldberg is asking, how important is a high genomic score in determining outcomes with Gleason 6 active
Okay,
surveillance?
so just go to PubMed and look at Carroll and prostate cancer. So again, I show these slides all the time, and I should have showed a waterfall plot where I track genomic score low to high and the likelihood of progression. So it is true that a high genomic score is associated with a higher risk of your cancer either being worse or getting worse, but it's not a yes or no. It's not like a pregnancy test. So it's just risk. And I show some people with a high genomic score who don't progress and some with a low that do. So what you do is you take that in as one bit of information. So I don't know that I make a treatment decision based on that, but I think if you have high genomics risk, again, hopefully you've had the MRI as well, you've calculated PSA density, but you put that into the equation. So generally for high genomic risk, high PIRADS, high PSA density, we consider an earlier rather than a later confirmatory biopsy.
You know, it might be useful for you to distinguish between like a somatic or genomic test
Yeah.
versus a germline test.
Correct. So both are tests. A somatic test is you're actually testing the cancer tissue itself. You're seeing how the cancer expresses certain genes. Germline testing is when you check the genes in your body. So it's either by a buccal swab or a blood test. So germline testing, I think, is important in men who have a strong family history, first-degree relatives with prostate cancer, certainly early prostate cancer or die of the disease. Also, you want to screen for early onset breast, pancreatic, or ovarian cancers. So again, men with a strong family history of disease should be undergo germline testing. The value, of course, is that you could tell family members about risk, because again, the risk goes both ways in men and women. And two, it turns out that men who carry these germline mutations, like BRCA1 or 2, may be candidates for a certain type of medication called PARP inhibition if they have distant disease. Also, we'll do germline testing if they have distant disease. Also, we'll do germline testing. We'll do it in men who have intraductal cancer. So in men with high-risk features of diagnosis, so large volume, higher grade, intraductal carcinoma, will get germline testing done as well.
How about Mike Wynn? He's asking, is a tumor in the transition zone more favorable compared to other areas?
So it is thought that it is, and for two reasons. There may be a biological difference. This transition zone, remember, is anterior and away from the nerve bundles. So I think these patients could be good candidates for nerve-sparing surgery, which we try and do most of our patients.
I have a question, Howard.
Yeah, go ahead.
Yeah, fine. In terms of ageism and what you just discussed with a family history, so is it possible that a person with a genetic, high-risk genetic results is more at risk given their age, elderly?
Well, so remember, as you age, it's more likely to get cancer in general, and the cancer you get tends to be worse. You know, early on, there was a discussion about the AUA not recommending PSA over the age of 70. Remember, there's a difference here. If you've had PSAs before age 70 and they're low, your future risk is very low, and you could consider not getting one after 70. But if you've never been screened and you're in good health, you may want to be screened. 70, the average age in this country is, I think, is 86. It's getting a little bit lower. Men are not living quite as long as they were. We've seen a reversible in this trend towards longer age. But you have to be very cautious. I don't make treatment. I rarely make treatment decisions based on age, because it goes both ways. You could overtreat a young patient based on age. You can undertreat an older patient based on age. So I'm very cautious. I tend to look at overall health and life expectancy, and family history.
Very good.
We've also shown that if you take men over the age of 75 who have high-risk tumors and you don't treat them effectively, you increase their risk of dying of prostate cancer. So you have to be very careful about making treatment decisions based on age alone.
Okay, thank you. Howard, it looks like we're coming up. We've had a long morning. I'm thinking of the doctor's time. How are we looking?
Well, you have the list in front of you. What do you think?
Well, let's see. Doctor, are you comfortable going a few more minutes?
And maybe there's someone there who's got a burning question you could ask. There's someone there in your messages who really needs to ask something as well.
Okay. Looks like we've got one here. PSA climbing very slowly, 3 to 7 over 5 years. Biopsy shows increased volume. 2 over 12 to 5 over 12 over 5 years with 50%. Is this volume a risk concern? MRI shows nothing outside the capsule at DRE smooth.
Yeah. So again, if you look at variability, the biopsy techniques have changed over time. And frequently I see that with time, people will oversample. That means that they may have a target that they'll do more biopsies on. So we've seen this. You have to be very cautious making treatment decisions based on volume when in fact the biopsy techniques have changed. So we've gone from more systematic and targeted. So I'm seeing now a lot of men get oversampled. By that I mean they'll get 4 or 5 biopsies from the target. And if you're using a volume cutoff, you could overestimate risk. So if it's still a low-grade tumor, I don't think you've lost anything. If in fact it's become a high-grade tumor, then a different story. So if it's a change in volume and grade is different than just a change in volume. So and just each time you get assessed, you go ahead and you look at things and make a decision. But I'm not sure I would change treatment based on going from 2 to 5. That could just be an artifact of the sampling.
I have a good question here that I think is relevant for everyone. This is Mark Perlow, who asks whether digital rectal exams are still considered beneficial.
So the answer is yes and no, and it depends who's doing it. So again, I think for population-based screening, PSA is the way to go, especially if an internist is doing it, because like me listening for the third heart sound, I can't do very well, and generally an internist doesn't do a digital rectal examination very well. But generally, it's not a good first-line screening maneuver. However, doing the DRE at some point does add to estimate of risk. So I think you could screen by PSA, but then might want to add a digital rectal examination, which is usually done at the time of MRI and biopsy. So yeah, I wouldn't screen with the DRE alone. It doesn't perform very well. But if you have an elevated PSA, adding a DRE has some value. Now the key is, well, if you're going to get an MRI, how much value does it have over the MRI? I mean, I think that's the real issue.
Somebody, Jim Murphy asked, can we have Dr. Carroll repeat his, I can't read this exactly, is it TZ or is it T2 cancer? TZ cancer favorability assessment. The audio glitched during his answer.
Yeah. So generally, transition zone tumors are often felt to be better for 2 reasons. One, there may be a biological difference. So a tumor rising in transition zone, and this was popularized by Tom Stamey probably, I don't know, 15, 20 years ago, maybe more favorable. Now, the other thing about a transition zone tumor, it tends to be more anterior and away from nerve bundles. So the approach to them may be more favorable. That means there may be more nerve sparing done. But again, when you look at origin, you also want to look at volume, grade, histologic subtype, genomics, and imaging. So I wouldn't make I've seen some very aggressive transition zone tumors, very aggressive. I have a patient now who's got a very aggressive anterior tumor. But again, there may be value to treating those patients because of their position, but you want to take into account all the other things, as I mentioned, genomics, grade, histologic subtype, imaging.
Okay. Howard, did you have any concluding remarks, or should we ask the doctor if he had any concluding remarks?
Well, I had a couple of things real quick. We had your colleague, Dr. Marks, speak a month ago. And he made a point of saying that he didn't become alarmed when PSAs reached as high as, until PSAs reached as high as 20. And has there been some reassessment? I mean, the propaganda that we got is, well, you're sort of worried when it hits 10. Is there, what's the story on a 20?
Well, the higher the PSA, the higher the risk, but you need to take into account everything else. So again, a PSA of 20 in a 200 cc gland is no different than so then PSA density, PSA alone, first of all, it varies, but generally, yeah, if you look at our risk of, the CAPRA score, PSA doesn't, any risk assessment tool takes into account PSA, but you have to go into the details about that. So a PSA of 10 could be an early warning sign in someone who's got a 20 cc gland and not a risk in a man who's got a 100 cc gland. So I think there are better ways to assess risk. PSMA has changed everything as well. So, PSMA is having a major impact on how we diagnose and treat this disease. So stay tuned for that.
And finally, doctor, I want to do a little advertising and disclosure. I am a patient at UCSF, still alive, mind you, after 13 years. I wanted to ask if you wanted to say a few words about your lifestyle, Dr. Chan and others. You have a wonderful diet book, things that people can access online at UCSF.
Yeah, so diet and lifestyle are increasingly important for overall well-being and overall health. And it's something that I think men with low risk cancers kind of gravitate to. And we have found that men who make lifestyle choices generally accept surveillance better. The lives are better. They tend to feel that they're doing something. And again, as I mentioned, the number one killer of men is cardiovascular disease, not prostate cancer. So again, read these booklets. Life has got to be worth living. So I think, you can make lifestyle changes that aren't burdensome. So changing your diet does not mean that you can't have meat ever, or to me a lot of this is caloric load. I mean, limit caloric load, avoid refined sugars, and just kind of eat less. Doesn't mean you can't eat well. We've looked at data on alcohol consumption. We saw some of our data on red wine looks good, but again, it's in moderation. But life is good. Got to be good. I mean, so adopt a lifestyle and exercise. Exercise increasingly be of interest to us, and to get benefits, you do not need to run marathons and stuff like that. You can get it other ways. Someone mentioned that I think the vaccine trial at Mount Sinai. We have a big interest in this, but this has got to be studied well. So that means I think you need good data on populations we can show the benefit. We have a big interest in mRNA-based vaccines. We can collect them now, but I think when you do clinical trials, you need to do them very well so they can answer the question. And again, the details are very important in this. A good clinical trial can answer a question where a trial that's not put together to answer the question can make things, I think, a little bit more challenging. Let me just say in closing, thank you very, very much. As I told you, we've done a few studies based on ideas that we've gotten, big studies, and so I learned as much from you as hopefully vice versa. I feel very pleased and honored to be able to speak today, and I take a lot of everything that's been said here gives me ideas to do more studies. But again, that one study from Howard on when to stop screening was a big hit for us.
Well, we'll come up with some more ideas for you.
Good. Yeah, and we do mention you there in the article. So, okay.
It's going to help my retirement account for sure.
Yeah, your H score. Yeah, it's good.
Yeah. So thanks to everybody. Mark, any final words?
None. I think we've covered it all, and thank you all for attending today. So, well, one thing I was thought about during this too, anxiety too can be fueled by the family. And so a thought for you folks that might find some family pressure around anxiety would be to show them some of the webinars that we've done, which may create some peace in your wife's life or your children's life or whatever. So that's a mechanism that may be of some assistance. There's no reason to get treatment if you don't need it, and so but you need support on that journey. Yeah. Thank you all.
Yeah, Jeff, do you or
you,
Peter, do you have that link for the material from UCSF?
I don't presently have it. I just would be ucsf.edu. Was that appropriate, Doctor?
Correct. There's a patient information page. If you just Google UCSF Urology, you'll go to our website. There's a patient information page. We have a lot of things there to download. That's a very good source. You can get it from Prostate Cancer Foundation as well. But it's 2 PDFs. It's very simple. And actually, most centers, including ours, have nutritionists. So frequently at your local hospital, they'll have you can have book an appointment to talk to a nutritionist about diet. And frequently now we'll see exercise guidance as well.
Yeah, I have a thought. Maybe Bill can add the link to the video.
Yes.
Okay. Maybe Jeff can supply it to Bill. So, Dr. Carroll, we thank you. Have a good rest of your day. Hope
Well,
to see you soon. And look for us in the funny papers, I guess.
good.
Thank you.
Thank you all. Bye now.